delirium is all about. It's a result of cerebral dysfunction in cerebral metabolism. It is very transient. It doesn't last for long. The condition, in most occasions, it's reversible, and the onset is usually acute or subacute. And in terms of manifestations or symptoms, there are a lot of neuropsychiatric abnormalities. So it borders between psychiatry and neurology. So delirium in itself is not a disease. It is a clinical syndrome. And by syndrome, we mean there is a constellation of symptoms, a number of symptoms put together, and that is what we refer by a syndrome, meaning that there is an underlying disease. And all that we are seeing here as delirium is a result of that underlying disease. It is a symptomatic manifestation of early brain or mental dysfunction, which can be as a result of any reason. And at the end of the lecture, we'll be looking at the very many of the various underlying diseases that may present with delirium. Now, that is a medical way of looking at the definition of delirium. However, in the streets, there's a common usage of this word. People talk of delirium as a state of drowsiness or a state of disorientation. So it's a word that is commonly used even in the common language out there. And what people mean when they say that they are feeling delirium or delirious is that they are drowsy or they're disoriented. And this is the most common usage of this word. But we now, as doctors, have a different way of looking or using this word delirium. So in common language, people say they've got a lot of pain, they feel they have no sleep, they're insomniac, or they're in emotional shock. We probably use the word delirium. That is in the streets. So the medical usage is what I've already alluded to at the beginning. There is usually a sudden loss in attention, or there is inability to focus. There is usually insomnia. The patient may be very, very agitated and very irritable. And who's talking? We proceed. Delirium, therefore, in the clinical sense, there is acute onset, there's loss of attention or focus, there are disturbances in cognition and disturbances in perception, and also the consciousness, level of consciousness fall.
Recording in progress.
That is, there is a reduced clarity of awareness of the environment. Just move on. There is this change in baseline levels of cognition. I've already mentioned that. And this cannot be accounted for by a pre-existing or established or evolving dementia. I don't know whether you've had a lecture in dementia, but dementia is a neurodegenerative disease associated with memory loss. It's commonly seen in people above 65 years, what we call the senile dementia. It may present initially like a delirium. And what we are saying here is that if a patient develops delirium and there is no dementia, then that is real delirium. But if they've had dementia previously, then maybe they may present a similar way like the delirium, but the main diagnosis will be dementia. Dementia has a very slow onset, whereas delirium has a rapid rapid onset. It is a fluctuating course in time, like dementia, where maybe the patient in the morning appears very lucid. Hours later, they may appear very, very disoriented with loss of all the abilities that we talked about, focusing, orientation, and so on. In summary, delirium has also been referred to as acute confusional state. It has also been referred to as acute brain syndrome. The key word in both of these descriptions is acute, meaning of recent onset. In terms of epidemiology, delirium occurs quite a lot in other areas of medicine, in surgery, post-surgery or post injuries. About 10 to 15% of the patients will have acute, with acute medical and surgical, 10 to 15% of patients on acute medical surgical ward will present with delirium. About 30 to 40% of elderly hospitalized patients will also present with delirium. And therefore, delirium is the most common acute disorder affecting adults in general wards or general hospitals. So in other words, what I'm trying to emphasize here is that it's a common presentation in surgical and medical wards compared to psychiatric wards. In fact, most of the patients in psychiatric wards will rarely present with delirium. What are the contributing factors? Number one, existing medical diseases. Patients with an already existing medical condition will present with delirium. And these are patients, for example, patients with cardiac disorders, patients in Burns units, patients with pre-existing brain damage, stroke, dementias, and so on. And number four is maybe the most important precipitating cause of delirium, that is any brain disorder. Other people who may present with delirium are patients on drugs of dependence, alcohol, and of course here we have a very common presentation called delirium tremens. We'll be telling you more about it in one of the lectures when we discuss alcohol dependence. Patients with conditions, for example, AIDS, or any other condition that may affect the central nervous system. People with very severe psychosocial factors, bad news that they may receive abruptly, they may present with delirium. Sensory deprivation, people who have been denied stimulation for a long time, they may also show features of confusion or delirium. And a good example there is sleep deprivation. If one goes for many days without sleep, they may develop state of acute confusional state that we refer to as delirium. What are the prodromal symptoms? What may precede the onset of delirium? The patient may appear so restless. They may show anxiety. They may be very irritable, and they may be insomniac just before they get into this acute confusional state. Now let's look at the details of how they they present. Number one, there's the inability to focus or maintain attention, and therefore there will be no coherent thought. When they talk, they will have a disorganized speech. They'll be able to focus or concentrate on a particular topic, and their thinking is not goal-directed. So you listen to them and you can't hardly make out what they're telling you. And we therefore say they've lost ability to focus. they'll be disoriented. And this refers to loss of awareness surroundings. They are not aware about their environment. They cannot tell you in the context of where they are, who they are, and what time it is. So they're disoriented for time, place, and person. They can't tell who they are, where they are, and what time it is. And the next slide is just emphasizing on that. For time, they don't know what time of the day it is, day of the week, month, season, or year it is. Place, they don't know where they are. And person, you probably ask them who they are, and they cannot precisely give you the details of their names and so on. For memory, they have inability to form short-term memory. That is, you give them a number, a phone number, for example, and you ask them to repeat it, then they can hardly do that. So there's loss of short-term memory. However, patient may retain previously formed long-term memories. That is, memories of which were formed long time ago or before the onset of delirium. But again, even this is not very well retained. Now, the other abnormality that we find or disturbance that we find in patients with delirium is in perception. The perceptions are very altered. There is misperceptions. In other words, they may have distortions in size or intensity of the surrounding environment. They look around themselves and everything appears very distorted, either in size or intensity. The size of people surrounding them may appear different, small, huge. It may appear darker or brighter than it is. They'll have illusions where they misinterpret perceptions. They see things that are known to them, but they give them the wrong names. A rope may probably be called by this patient by another name, for example, snake. They have poorly formed hallucinations. To be telling you, hallucinations are false interpretations. So they hear things that probably do not exist. They see things that are not in reality there. So they have poorly formed hallucinations, unlike what we see in patients with schizophrenia. What type of hallucinations or false perceptions do patients in delirium experience? They may experience visual hallucinations. And in this, there are distortions in form of what they see. They can see masses of small crawling creatures. And patients with a condition that I alluded to previously, delirium tremens seen in very severe alcohol withdrawal, patients may complain of seeing many insects, either they are crawling on their skin or they're on the floor. They may see multiple other objects that frighten them, and this can be a cause for alarm. And this maybe makes them very anxious, fearful, and they may demonstrate other behavioral problems like defending themselves from these attacking creatures. They may have delusions, and delusions are defined as false, strange beliefs. They may believe that they have turned into something else. They're no longer a human being. They probably have turned into a snake, horse, or something like that. However, these delusions are very temporary. Now, the delusions that we find in other conditions like schizophrenia are long-term, where they have these false beliefs, strange ones, and they last for a long time, maybe their entire life. But in delirium, they're usually very temporary. However, in some few patients, those delusions may persist a little bit longer. The other disturbance that we see in delirium regards the affect. The patient may appear to be in terror, and I gave the reasons why, maybe because of the hallucinations they're experiencing. They display sadness. They may be joculous, but the jokes seem to be very empty. They may appear very irritable and angry, or they may be euphoric. So when you look at, when you examine the affect, it appears terribly out of the expected. How long does delirium last? As I said a little bit earlier at the beginning of this lecture, delirium is affected by the underlying cause. And once the underlying cause has been taken care of, the delirium will also cease. For example, if the patient had fever and they showed symptoms of delirium, the moment you treat the fever, then the delirium also subsides. In most situations, delirium rarely persists for more than a month. And should it happen, should it stay longer or last longer, there are permanent decrements in cognitive functions. In other words, there might be long-term complications where the cognitive functions are impaired permanently. And this may show as loss of memory and reasoning power, and there is increased risk of dementia in the years that follow. So although we say that delirium lasts for a very limited period of time, in a few cases, it may be a bit permanent and may cause more cognitive damages, resulting in risk of dementia later on in life. Now, what is the etiology of delirium? As I said at the beginning, delirium is not in itself a disease. However, it is a manifestation of an existing underlying disease. And we can possibly list a number of possible causes. Number one, many organic causes or diseases, and this can be either structural defects in the central nervous system or metabolic problems in the brain. As I had mentioned a bit earlier in the beginning, we did say that delirium is actually a metabolic disorder. It results from metabolic problems, and we'll be looking at the problems in a little bit more details later on. Delirium can also result from psychiatric disorders, especially people with emotional stress or real mental disorders like delirium tremens, which I said is a complication of alcohol use disorder. Delirium has a fluctuating cause. I've seen a question there. Let's proceed to respond to it. Delirium has a fluctuating cause. In other words, you may probably find a patient in the morning and maybe examine them later in the afternoon, and you find that maybe the symptoms are no longer present. In other words, it's like they have improved, but in reality, it is not so. It's just a cause of the illness. So within the week, there may be variations in the intensity of the symptoms. So the attention may decrease, the arousal may be very disturbed, the sleep-wake cycle may be disorganized or disturbed, thinking and speech may also be disorganized. There are some neurological abnormalities, dysgraphia, they can't write a sentence, They can't construct something as to draw a crop. They're not able to do that. They cannot name objects, dysnomnia, apraxia. And when you do their EEG, the background may show abnormal features. So those are neurological abnormalities that you may find in delirium. There are also motor abnormalities. They may present with tremors, hysteresis, myoclonus reflex, and the tone of their muscles may also change. Now, this lecture focuses more on the psychiatric manifestations, and according to the DSM-5 diagnostic criteria, then this is what you should look for. One, there is disturbance in attention. There's a reduced ability to direct focus, sustain it, and it tends to shift quite a lot. And they may appear very, very disoriented. I mentioned this at the beginning. The disturbances develop over a very short period of time, maybe hours to few days. And this is a change from the baseline. Attention and awareness tends to fluctuate in severity during the course of the day. And I had mentioned this a little bit earlier, meaning that they may appear very, very lucid in the morning and worse in the afternoons in the same day. And we should be able to demonstrate that there's no pre-existing dementia. And I told you dementia is a disease of memory loss that occurs mainly in the elderly, people in their 60s. So the disturbances in cognition are prominent, where there is memory deficit, they may have disorientation, language may be disturbed, there is also visual spatial ability is lost, and of course there are some perceptual disturbances as well. To continue with the criteria, of course, the disturbances that I've mentioned are not due to a pre-existing or evolving neurocognitive disorder, and they do not occur as a result of coma. So this is not coma as a differential. The other criteria is that there's evidence that the disturbances that we are seeing are as a result of physiological consequences of another medical condition. And this one is the most important thing, that delirium is a consequence of an underlying medical condition. There is a good example there, substance intoxication or withdrawal symptoms, or it could be many other causes that I'm going to mention in a short while. What are the differential of delirium? Dementia, but again, we say dementia tends to occur in elderly people, and it has a very gradual onset. It is not acute, and therefore we can be able to distinguish between dementia and delirium. Depression, again, can be a differential, but again, depression has many other features. For example, sustained mood changes, which are not the case in delirium because it tends to fluctuate quite a lot. Psychosis, again, will present with more severe perceptual thought, cognitive symptoms which last over a long period of time, unlike the ones in dementia. And the onset again of psychosis is also very gradual. Now, let's look at the many causes that can cause delirium. Uremic encephalopathy. Any disease can result into delirium, hypertensive encephalopathy, can result into delirium, withdrawal symptoms or withdrawal syndromes of the very many substances, alcohol, heroin, cocaine, and so on, can present with delirium. Hypoglycemia can present initially at the beginning with signs of delirium. Hypoperfusion of the central nervous system for whatever reason, hemorrhage, and so on. Hypopnea again can result into delirium from whatever reasons. Intracranial pathology, if there is any bleeding intracranially, infections such as meningitis can result in delirium. Poisoning from gases or heavy metals. Some medications, antibiotics, anticholinergic medication, and some anticonvulsants can also result into delirious states. Now, the easiest way to remember what causes delirium is a mnemonic called "I watch death." This in quotes, "I watch death," and every letter here stands for something. Let's go through each letter and fill in the details. For example, I stands for infections, right? And I've listed a number of infections there: encephalitis, meningitis, syphilis, pneumonia, urinary tract infection, and the list can be long, right? So infection can result into delirium. Now, W stands for withdrawal syndromes. Withdrawal syndromes of very many substances of addiction, alcohol, barbiturates, sedatives, hypnotics, opiates, and the list is long. There are about 11 substances, and all of them can result in withdrawal, but these are the ones that are commonly associated with delirium. A stands for acute metabolic states. For instance, acidosis, alkalosis, electrolyte imbalance, hepatic failure, renal failure. Any acute metabolic state can result in delirium. And from your medical wards and surgical wards, this will become very clear. T stands for trauma, and we are talking about post-operative states, severe burns, or any acute pain. So, although they all appear in one line, you should split them: post-operative, states. Number 2, severe burns, acute to severe pain. So trauma can result in delirium immediately after it has happened. C stands for central nervous pathology. If there is any pathology in the central nervous system of whatever nature, abscesses, hydrocephalus, seizures, strokes, cerebral hemorrhages, all these CNS pathologies can result into delirium. Central system pathology continued, head trauma. There is, for example, concussion, traumatic penetrating injuries. This is a very serious, state to be in. Head trauma can maybe result in delirium and subsequent pathologies result into very severe cognitive disturbances. Gross structural damages from brain diseases and tumors, again, can result in delirium, but the long-term effects are more serious than delirium. Delirium may probably be the initial stages, but subsequently dementing processes may present. The various neurological disorders, and I'm not listing them, but very many other neurological disorders can result into delirium. Lack of sleep, we talked about it a little bit earlier. Hypoxia from whatever reason, anemia being one of them, carbon monoxide poisoning, hypotension, pulmonary or cardiac failure can result in delirium. Now, nutritional deficiencies, for example, B12, thiamine, niacin, that is repeated there, can result into delirium. Endocrinopathies, any abnormalities in the thyroid, parathyroid glands can result into delirium, and the list is long there. So endocrinopathies can present with delirium even long before you're able to diagnose an existing endocrine disorder. Acute vascular disorders, hypertensive encephalopathies, stroke, and many others. Toxins, here drugs that are prescribed, and also those that are used as drugs of addiction, but mostly toxins can result in delirium. Heavy metals, lead, manganese, mercury, all this when ingested can result in delirium. So how do you make a diagnosis of delirium? Number one, you need to take a very good history. Sometimes the history will have to be collaborative history because the patient may not be able to give you any history. You observe their mental state. You do the physical examinations, the laboratory examinations, which are indicated depending on the history of the physical examination. So you do the basic investigations. We may do a little bit more. The imaging and whatever else you think is necessary to do to make a diagnosis of what the underlying disorder is all about. In terms of treatment, when the etiology or etiologies are known, then you treat that primary disorder, so the primary disease. Now, when the etiology or etiologies are unknown, it becomes very difficult, but you do the supportive treatment, keep them in a safe place, nurse them well, and sometimes the delirium will resolve on itself. So the management will involve the medical interventions, where you probably do pharmacological interventions as well, and also psychosocial support. What's the prognosis of delirium? Delirium is not well handled. Has a very high mortality, and this may range up to 10%, depending on the type of care that the patient receives. Good. Now the question is, why do we teach you this? This is because there are a few psychiatric disorders which may present with confusional states, and you need to distinguish whether there is any underlying disease, because that is what you need to treat first. However, you can get cases where people present with acute confusional states in anxiety, even in depression, in intoxication, and making the differentials. Knowing the differentials is very important, so that you treat what really is causing this confusional state. That's all about delirium. Now, Kyoko Mweo had asked us to make some clarification. Kindly repeat the differences between misperceptions, illusions, and hallucinations. Yes, I know you're in the early stages in psychiatry. You'll be hearing more about psychopathology, and that is a abnormal state of mind. Now, hallucinations are states where the individual perceives, and yet there is no stimuli. For you to be able to say you've seen a dog, you must have seen a dog, and everybody else will have seen a dog. However, in situations where it's only you who say that you've seen a dog, and yet everybody surrounding you has not seen a dog, then what we say is that you're having hallucination. There is no stimuli, and yet you are able to conclude that you have seen something. That is a hallucination. It can occur in various modalities. It can be either visual, it can be auditory. You hear things that other people are not able to, and it can be gustatory, depending on the five senses. In illusions, the patient will probably see, but then attach the wrong meaning. So they see a rope and they call that rope a snake. So you differentiate here between illusions and hallucinations, in that in illusions there is a stimuli, but that stimuli is misinterpreted. In misperceptions, perception is the way you interpret any stimuli. So if you do it wrongly, then there are misperceptions, yeah, such as the delirium, such as the illusions, and of course the hallucinations that we've talked about. Somebody is saying, kindly repeat on how to diagnose delirium. As I said, delirium is not a medical disease on itself. And the most important thing about delirium is an acute confusional state. Go through your notes again, and I did mention in the last summary that delirium equals to acute confusional state, where there is disturbances in their cognition, there are disturbances in orientation, right? They have disturbances in time, place, and person, which is of an acute onset. Now, in terms of the mortality rate, it depends on the source of the figures. The most important thing I've mentioned that delirium has high mortality rate depending on the care that is given. If you are not able to get these people in good time, the mortality can go up, and the percentage doesn't really matter much. But the most important to note is that delirium has a high mortality rate, depending on the center that is taking care of the patient. Now, somebody is asking, what is the cause of death in delirium? Is it the underlying cause? True. True. We say that delirium is just a manifestation of underlying cause. If that underlying cause is not well taken care of, if somebody is in renal failure, if somebody is in cardiac failure, they're presenting with delirium. Delirium is just a manifestation, it's just a symptom. It's a syndrome. That's what we said at the beginning, a constellation of very many symptoms. What is likely to cause death will be the underlying disease. If it is renal failure, cardiac failure, intoxication, head trauma, and so on. Somebody is asking, what is the most affected age group? Again, all the groups are vulnerable depending on which disease they are suffering from. Good. Any more chats? Khan?
I think we're okay, Doc.
You're okay.
Thank you so much. Yes, thanks so much for the class.
Okay, thank you very much, Khan and Levine. You've been very